Oh, never mind.
There you go. There's your warning. We are recording. I forgot to record last time, so apologies to anybody who wasn't here for the last meeting, and I know I wanted to watch it online and I forgot to record it, so. Going to try to be better. That, 2026, record them all. Just taking attendance real quick in the room. That won't be
I don't know where those are supposed to sit here, but.
So for all of those online, we're talking a little bit about in-person versus online attendance. And it is definitely preferred if you guys can come in person for these things because, you know, I try to combine a little bit of what's changing equipment wise, what's, you know, new protocols, all these things. And some of that requires some in-person display or presentation. And this is a good opportunity to do that and tick off a lot of people at the same time. So what we're kind of thinking is that if you live really far away, fair enough. If you're coming off shift and you got your butt kicked, fair enough. But otherwise, if people could attend in person, that would be really, really great to see the movie used that way.
Cause I didn't even know.
Yeah, so everybody has an Outlook calendar and they have a Teams calendar. Check your emails, check your calendar, just once a week. Just once a week, just check it on a Monday. That's all you have to do. But I do agree with you. I meant to send it out yesterday evening, and then my kid punched another kid in the face at school yesterday, so I had a little counseling to do. when I
Can you
got
put
home.
it on a lab tech?
If they deserve it.
That way it shows up and we see
Yeah,
it.
he did, yeah. Yeah, it was self-defense more than anything.
Because we can't subscribe to the Outlook calendar.
But it was a third grader versus a fifth grader, and, you know, so, and mine's the third grader, so. Yeah.
Did he win at least?
No. No, he got his butt kicked. He didn't punch the kid in the face, so. The fifth grader just thought it was funny. Which is fair enough. He's a big kid. He didn't get hurt or anything. It wasn't that big a deal, but. He'll be fine. Okay, so,
Oh, my God.
today's, presentation is gonna be,
Thank you.
we have 3 cases to discuss. They're all around traumatic brain injuries and RSI. And some recent changes to our protocols and also a refined RSI checklist and induction kind of guidance chart, okay? So we're going to hopefully have Dr. Burtis here as well to help explain a little bit of the rationale behind some of these things at some point during this morning. Let's keep our fingers crossed. Dr. Burtis is usually, I mean, he's running 20 minutes late usually. So, but we got a few more. Not Dr. Burtis, but I'll take Drew. All right, let's dive into it. Okay, so can everybody online, first of all, hear us? And can you see the presentation? A thumbs up or a wave or a heart emoji? Thumbs up?
Thumbs up.
Lovely. Thank you all for that. Right, so specifically, we're going to be talking about 3 cases, RSI for hemodynamically stable traumatic brain injury patients. And that's kind of a really important point about the hemodynamically stable patient when we go to start talking about our induction chart here, okay? We've had a few changes that have just recently come down and discussed. Was it late last week? I think it was Friday. We started discussing this. So the medical directors for ASL and obviously Dr. Burtis got together and looked at a little bit of information on patients who are receiving high flow oxygen. And these used to almost be exclusively crit care transport patients. But what they've done to kind of help move patients over to the ALS side a little bit more is reduce unnecessary critical care transfers. And what we're talking about here is for patients that are on high flow oxygen. Okay, ALS can be sent on these calls. It's obviously within our scope of practice to deal with any patient that's on oxygen, right? But what we're specifically talking about, morning, Dr. Burrs. Lovely that you're here.
8 minutes.
No, that's okay. That's on time.
20 minutes.
That's on time.
Right.
You missed all the fluff, so it's not that big of a deal. Where we're just briefly talking about is some changes here to transfers of high flow oxygen patients. So these are patients that are not going to ICU. They're not going to pediatric ICU, okay? But they might still be on fairly high flow oxygen. We're just going to be moving these patients over to ALS when appropriate so that we keep our critical care transfer service available for real critical care transfers, okay? If you have any questions specifically about a patient, right, make those questions known once you get to the patient and have a look at the patient, right? This isn't a catch-all change. This is not going to be 100% fit for every patient. You still have to go and assess your patient, make sure that they're appropriate for you, okay? But the idea is that many of these patients might be on, high flow nasal cannula in the hospital, which is quite comfortable, humidified, oxygen, right, or blended air. We don't have the capability really to do this as far as the equipment that we have in our ambulance all the time. I have seen people bring hospital equipment, specifically the air through the bubbler situation that you can attach to some of our I think they're the ball float oxygen regulators. So there are a few people that are already delivering some humidified oxygen to people in the back of our ambulance. The other thing that you can certainly consider with some of these patients on a high flow nasal cannula is to see if you can transfer them over to CPAP or BiPAP, right? And put them on a little bit of PEEP or a little bit of BiPAP, if that's what's going to help, right? So what we're kind of talking about here is patients who are going to be a little bit of a longer distance transfer, right? So these are probably going to be your Wood Rivers to Boise's or you're here to Boise's. I would be very suspicious of a patient going from here to Utah because that is a very long transfer on high flow oxygen. You would have to generally run the calculation to make sure that you have enough oxygen in your tank to get your patient there, okay? Especially if they're on high flow oxygen and they have a very high respiratory rate. They could potentially suck your bottle dry over the course of 3+ hours, okay? So just be wary of those patients. Any questions with this? Dr. Burtis, do you have anything to add to this? No. Lovely. Okay, so just go and assess your patients, make sure that they're appropriate for you.
It's always nice when it's a 90-minute drive to get there.
Yeah.
Oh, yeah, this patient's.
I think we can, I wish this would have been brought up like sooner, because I kind of disagree. If it's out of Wood River, we shouldn't do that. If it's out of Twin, we can come and assess. We can't send a crew to 2 hours, get up there and go, yeah, sorry, you're SOS.
This is critical. Now we run back.
That makes no sense. Wood River should be taken out of that one. Yeah, I mean, there's too many things that can happen between here, there, once we get there up, and then now the patient's 6 hours, and then we're getting stuff. I think whoever made that decision should have asked one of the crews.
I think that discussion is that Air St. Luke's crew up there now, is if they're available, they can go put eyes on that patient first.
They can, but they don't. I can tell you that because we just had that the other day. They sat in the quarters and the crew went all the way up and got in there and they weren't anywhere to be seen. So we can request.
It's a new vacation station.
No, I don't know. I just think it's not,
I mean, it's a work in progress.
yeah, but I think that one should be we should look at a different way of doing it, personal.
I think you need to interrogate those pretty hard. as a
Yeah.
supervisor.
Well, the problem is, we don't get that, we don't get who we can talk to, and then you get, when you do that, then we get, well, you guys just need to go up there and do it, we need to do this, it needs to be done. You get on with the nurse, or you get whoever's calling, and they're like, well, so you don't wanna do it. I mean, it's not as easy as asking all the questions, because the answers you always get are pushing that direction, you don't.
You're talking to a guy
Yeah.
who used to go get these guys all the time.
Exactly. And that's why I'm just saying, I think Wood
Information
River's,
is good.
Wood River's a long ways from something like that.
Well, and to support your theory, we don't send a BLS crew, a BLS
Yeah.
patient.
Exactly. Yeah.
So we make sure they're in the. I think if you have a patient that is termed to be on a high flow oxygen in Wood River, there should be some definitely reconsiderations. If you get up there and you're an ALS crew and you go up there and you didn't have that information up front, they converted them to that, then we're gonna
That's
manage it.
I mean, if it changes, and then, I mean, that was also the other change we need to look at is going to Utah, they're calling us first still, so. I mean, I'll bring that up later on, just so. I think that's a dispatch.
Yeah.
Just so you guys know, we do look at it, we do try to help, but that's a huge one.
Like, I mean, you guys are, the supervisor level is the gatekeeper from those, from the. And so, you know, and it is, sometimes it's very labor intensive to interrogate those call-ins. And people don't want to share the information because they're either under the pump themselves and they don't want to be on the phone for 20 minutes explaining it to you, or they just want to get that patient out of some, right? That's,
100%.
yeah. And it's an emotional decision many times.
You know, it's hard.
Yeah. It's hard to be objective in those situations, yeah.
Thank
All right.
you, appreciate it.
Thank you very much for your input there, James. It's always valuable. So today's case review objectives, we're going to look at 3 different traumatic brain injury patients. We're going to look at our new kind of revised RSI checklist and induction guidance chart. We're going to look at the pharmacology around those induction agents. We're going to look at some interventions applied to the cases and why those are important. Treatment and transport decisions, a couple of these were flown out, and also our applicable protocols for TBI. So here's our new look RSI checklist. All right. It's going to be full page, right? This is going to be just front and back. We got originally when this was kind of pushed forward to the group for discussion, it was a 4-page document. And it was just, I thought probably not going to get utilized because of the length of the content, right? 4 pages is a lot to deal with. While you're doing an RSI, it's much better if you just have one laminated sheet, front and back, that you can flip over. The sheet's large enough for you if you want to have a whiteboard marker to actually go through and check these things off if you have time, or it's just a challenge response list, right? So I've used these in the past with quite a bit of success. They've saved my behind on several very difficult RSIs that I have done in the field, mostly around the emotion of those jobs. They're, you know, people are yelling and screaming at you to take care of their family members, and your brain space is caught up by the emotion of what's going on. It's very nice to be able to pull that back and address what you're doing off of a checklist, right? So that's kind of our newer look to the front page, right? Our back page is very much condensed from the extra 3 pages that we had before, okay? So we've got your simple airway algorithm on the side. We've got our induction and sedation and vasopressors kind of cheat sheet there. And what we did look at was condensing our induction, pre-medication, and paralysis doses down to about 5-inch height markers, right? Because it's very difficult for me to tell if somebody is 5'1" or 5'4" looking at them. And even with a tape measure, if I'm looking with a tape measure, I'm probably not taking into account every little nook and cranny, right? Are they head up? I'm stretching the tape measure out. A couple inches really does not matter too much as far as our dosages here, right? What we're also working off of is more of an ideal body weight instead of an actual body weight for these charts, okay? So what we've done is really simplify our induction chart here, right? We've also included something that I really rarely see in all the RSI charts that I've read here, and Dr. Burtis can probably talk to this a little bit more, which is pre-medication with fentanyl. We don't really seem to pre-medicate our patients very often with an analgesia or an opioid. We're usually doing etomidate, rock inductions, at least from what I've seen, probably about 90% of the time. The research on what you do in an induction, especially in a pre-hospital patient, is limited, but what we kind of do know is there are specific patient populations where a pre-medication would be a good decision, right? And we'll go over that and the reasoning behind that. Underneath, we've got sedation and analgesia, right? So these are your ongoing kind of treatments for your patient to make sure that we don't have a patient with awake paralysis or a patient that we're trying to optimize, especially a traumatic brain injury patient that we're trying to optimize from a, especially a sympathetic nervous system response from the pain can really drive up our, our perfusion pressures in our brain and eventually our intracranial pressures. And these patients can have, bad outcomes because they have too much pain. So this is a nice little way to kind of remember what we're doing. It's a safe way to check where you think your dosages should be. And these are just generally guidance, okay? This doesn't limit you to what you're doing, right? If you want to tailor a medication for your patient's presentation, we absolutely support that, right? This is just a quick reference guide for when you're under the pump and you want to make a standard decision for a patient, right? By all means, if you estimate your patient's weight to be 94 kilograms and you want to do the math for 0.3 of etomidate at 94 kilos, you can. Nobody's saying that you can't. But what we're saying is that you can use these ranges to your advantage as you see fit, okay? Because these are all fairly standard inductions, paralysis, and pre-medication ranges for your patients, right? The fentanyl pre-medication, we'll talk a little bit later on, is probably somewhat dependent on the patient hemodynamics. And that's why we bring that back to our first slide, which was stable patients, okay? Over on the right side of the screen there, you still have your 7 Ps, just to kind of remind you of those things that is repeated on our first page. And then your Lemon Law is for your anatomical assessment of your patient's airway, right? So, is anybody doing a lemon when they go to intubate somebody in the field? It's saved me a few times, right? Looking at patients and going, right, I really have no neck, right? This is probably going to be a very tight airway. I should probably try a bougie, right? Versus a Stylen. Gives me a little bit more of an option. Or I have terrible mouth opening and what looks like a fairly anterior airway. Maybe I'll try my X-blade, right? And hyperangulate my tube, okay? So assessing the anatomy of your patient is, I think, fairly important.
One of the challenges with the Malum patty is the proper way to do that is an alert, awake patient who's able to sit up and open their mouth.
Yes.
And that's why we've taken it off the documentation side of things.
Yeah.
Because our patients don't really need that.
Yeah. Yeah, you're not gonna get very many patients in pre-hospital that will be able to open their mouth for you. Maybe a breather for a minute or two, you know, that might be about it. They might be able to follow some commands for you. That's about kind of pre-planning on those patients. If you see somebody going downhill and you're like, I got an hour until I'm somewhere for help, right? If your patient's able to follow commands, maybe you look at a mount patty very early on to give you some guidance, because you have a significant suspicion that the patient's going to get tubed. I don't know if you do that in ED when you see somebody come through the door, that you're like, that person's going to need to get tubed in the next half an hour, 45 minutes, right? We don't really delay that decision because it's very hard to pull over half an hour into our transfer. Mentally, that is a big block, right? I've literally had to ask the pilots of the machines that I'm flying to go and land somewhere so that I could RSI a patient that took a crash in the back of the aircraft. So we can definitely pull over. We can definitely pull over in a safe space. I know it doesn't happen very often, and I will raise my hand and say I'm absolutely guilty of just trying to manage things on the run. But if you're going to be doing an RSI, right, and it's a delayed RSI, or, you know, what they call a DSI, right? You can do some of these things very early on in the piece, resuscitate your patient for a good long while, and maybe prevent them from being intubated, right? You can try CPAP, you can try BiPAP, you can try these things. And eventually, if they go downhill and they have respiratory failure, sometimes there's nothing you can do. But you've done your assessment prior to that, right? So that's a really good point, Stan. Thanks for making it. Case number one, let's get into it.
Yes.
Yeah, this was a very, very interesting case. Kenzie actually brought this case up for me to have a look at. Pretty interesting case. We've got a 41-year-old male, recently released from prison. He's winning in life. He was intoxicated and causing a public nuisance. He was agitated and aggressive with police, and so they tased him. The initial impression was a patient who had police on top of him with a soiled, bloody airway and a combative brain injury. He needed airway management for some pretty significant airway issues, and he was treated and transported by us.
Yeah, I think so.
TBI, basically. Or like.
Yeah, I mean, potentially, yeah. But I think
If you ask the
his
cops.
CT scan, there was some interesting stuff on there. Say that. Okay, so who do we have? We've got Mackenzie, like I talked about before. We've got Josh. We've got Ken, and we've got Noah's kind of introduction to real life EMS. I think he had some pretty good jobs on his FTO as well, but this would have been probably a little bit of an eye opener for young Noah.
He said it was his favorite semester.
Yes, I do. I remember that now. Yes, it was like right at the end of his training, wasn't it?
His kid, got spit on her.
Yeah, I remember. His
The nation's.
So we've got a very quick dispatch time. We have a very quick shoot time. And we're on scene with the patient in 4 minutes after dispatch. So there's not a big delay. Well, actually, no, it took a little bit of time. At patient is 9 minutes after dispatch, or en route, sorry. And we're leaving with the patient, we're moving the patient to the ambulance very quickly. And then realistically, our on scene time, 19 minutes for an RSI is, that's good. That's great, right? You know, in my previous life, we used to shoot for anything under 30 minutes was acceptable, right? 20 minutes was the gold standard. But anything under 30 minutes to prep and do an RSI was acceptable time, right? And this patient was a very challenging patient. Obviously, we've got, I think, of sheriff's office on scene, and we've also got Twin Falls Fire, or do we have Kimberly? Twin Falls. Okay. So we have lots of hands and lots of help. And 4 MVP staff, okay? So we've got a patient with a puddle of blood next to them. We've got no purposeful movement noted, but at times the patient is quite combative. And he began vomiting when they started moving the patient, right? The dispatch information, or why you guys were called, was the patient was acting irregularly. That was a very nice way to say being combative with the sheriff's office. And the patient fell on their face into the ground after being tased, and now they're bleeding from their ear. Say again? Oh, so he was running and they tased him, I think, in the neck and neck in the back.
This is my favorite cop call.
Yeah. So he's fallen down on his face. He's got a pretty significant hematoma to his face, and we'll have a look at the CT scan of his face a little bit later. He's known to have a taser barb in his neck and lower right side of his abdomen. The barbs are removed. He does respond to pain, and he's vomiting quite a bit with increasing amounts of blood. His initial GCS is 7, but his eyes are swollen shut. So that'll tell you a little bit about the impact to his face.
They had drug him about 10 yards from the center of the road to the bar.
Yes. Yeah, so he's had a pretty significant injury, right? So let's look a little bit of, the kind of population kind of science around traumatic brain injury here. Okay. We've got a lot of patients who have traumatic brain injuries, right? We've got over 50,000 deaths attributed to traumatic brain injuries. Over 250,000 people are hospitalized, and 1.4 million require a ED visit, and the total cost to society is staggering, right? We're probably, and this is, I'm not sure when these stats were taken, but I would imagine we're burgeoning probably on $100 billion with the traumatic brain injury costs, right? 75% of these are concussions, and those are obviously fairly low grade. Okay, so that's the good news, if there is any in those statistics, right? So we all know the serious symptoms of a TBI, but the majority of our TBIs are suffered by children and teenagers during sports. Okay, so be suspicious in that population. We don't have any children or teenagers in our cohort for today's case review. Luckily, those are pretty sad. But we do have somebody involved in sport in one of ours. Okay. We have some really long-term side effects from TBIs, right? And we'll have a look at that in our patient kind of review, what happened to our patients. Okay. So let's look at the mechanism of injury for this patient specifically, right? We've got definitely a direct impact injury, right? When your patient's running at a full tilt away from the police and they tase him, he loses the capability to brace himself and directly impacts the front of his head. Luckily, that's a pretty good part of your head to hit onto the ground. If you're going to hit anywhere on your head onto the ground, your forehead is definitely a good place, right? Anatomically speaking, that is where your skull is the thickest and actually has the most padding. So it's not a terrible place to take a hit, right? But this patient, as we'll see in the review of his injuries, had a little bit more than just a direct impact injury. So we have a lot of these direct impact injuries that cause a contre coup effect, right? Where one part of your brain takes the initial blunt impact, and then the other side of your brain, when it comes to joggling around inside of your skull, gets injured as well. or just the sheer impact, we can get shear force injuries as well. Let's look at our head injury protocol. Okay, not all of this is applicable to us, but it's good to talk about all of it nonetheless. So what do we kind of term a hemodynamically stable traumatic brain injury? Well, we can kind of see here that we're shooting for some specific numbers, right? Systolic blood pressure over 100, but less than 160, right? Those are kind of our ideal numbers when we're dealing with a traumatic brain injury patient. So we want to manage our fluid appropriately, manage our pressors appropriately to keep our patient's systolic blood pressure above 100 and or a MAP above 65, 70, 75, somewhere around there.
Above?
Yeah.
Is there like a number we don't wanna go, obviously we don't wanna go to, just like 110, 120, okay, or do we wanna stay?
I mean, mean arterial pressure,
Yeah.
110, 120.
Because I think it should be 60 to 100.
It does depend on the patient's presentation. I think I probably refer this one to Dr. Burgess for an opinion because I think it does depend on how swollen the brain is.
What's the question exactly, sir?
What's the high number from the map pressure? Do you want to keep it under 100 or under 1?
So, I'm sorry, I'm not quite following the question, but, so.
It's the high on the map.
High on the map,
Yeah.
well, that's the problem is we're not really treating blood pressures on these patients, bringing them down. I think the goal is to try to optimize to normal tension somewhere in that range. The problem could be, it's not really something easy to put in a protocol when to treat a blood pressure on somebody who's had a head injury.
Yeah.
And especially in that field, if they have like an intracranial hemorrhage, like a traumatic one, there could be mass effect. If you do treat the blood pressure, you could actually underperfuse them. So I think it's just more or less the point is this comes from a study where patients tend to do better when they're normotensive, normal oxygen levels, not retaining CO2. So I don't know if there's a good answer for that, to be honest. It's a tough one.
We'll try it.
Try to, yeah, I mean, I guess one reasonable thing is if you think there's pain, possibly treat that. Maybe that will help with the blood pressure, but we're not really, I guess, like it says, you could contact them and see if they want to treat the blood pressure. Generally, you're not going to get a request to give blood antihypertensives to a patient like that, just for the off chance that they may have mass effects. So it helps when you have a head CT, you can get a better answer to that.
No, yeah, we haven't got those control kids.
So you can kind of defer that decision to the neuro specialist,
Yeah.
right? Who's going to be in charge of these patients because I've had patients with all different types of brain injuries and had all different types of target pressures for those patients given to me by the neuro intensivist, right?
It's an easy answer if, say, they have an intraparenchymal hemorrhage from a stroke. Like we have good data on blood pressure parameters. When it comes to traumatic head injuries and blood pressures, we do know that patients in an acceptable range or in a normal range do better. But there's also not a good data to say treating. So we actually found, like with SAGE, like spontaneous hemorrhages from stroke. We have good data to say, like, if you treat the blood pressure too much, you could be into trouble. But we like set that goal of 140 for those patients. Those same studies don't really exist for stroke. Right? Yeah, that's going to be a problem. So you're going to be all over the place with what the recommendations are.
Right. The main problem for a lot of these traumatic brain injured patients is they have multiple sites of injury inside of the brain, right? So they'll have a subarachnoid hemorrhage, they'll have an intracerebral hemorrhage, and they'll have a diffuse axonal injury, right? All into one. And it's like, there's different goals for each one of those types of brain injuries. So I think, what Dr. Burgess is saying is when you look at the numbers of 100 to 160, that falls within physiological norms, right? So if you're shooting for physiological norms for your blood pressures, that's great. But if your patient's running over 160, you make another really good point. Consider pain response. right? The last time I hit my head, it hurt, right? And that's, I mean, it's dumbed down really a lot, that statement, but it's very painful to have a head injury, okay? Pediatric, obviously, we're gonna do our age appropriate blood pressure. When we kind of look at that, it's 70 plus 2 times the age is kind of our minimum systolic that we're looking for, right? 80 plus 2 times the age is kind of the physiological norm that we kind of shoot, right? Avoid hypervolemia, right? Hypovolemia is bad. Hypervolemia is also bad for these patients, right? And that goes back to a principle called cerebral blood volume. Okay, the more volume we push into a patient, the more volume we're going to push into their head. That's just the nature of what happens, right? So we don't want to have too much volume inside of the cranium because that increases your intracranial pressure and will eventually decrease oxygenation, perfusion, and other key parameters for brain health. Okay. Supplemental oxygen is a mainstay for these patients, right? As soon as we have a patient with a reduced GCS suspicion of a traumatic brain injury, get them on some oxygen, especially early on if you think that they're going to get tubed, which all 3 of these patients are tubed, right? If we get them on supplemental oxygen early, you're going to help flush out that nitrogen right in their lungs, and you're going to build up a reservoir of oxygen to help the patient not become hypoxic, right? Hypoxia is a secondary brain injury for many of these patients, right? Avoid low end tidal CO2s and try to avoid high end tidal CO2s. So again, shoot for your physiological norms, 35 to 45. If you have any suspicion that the patient might be having impending herniation, right? So when your patient's brain swells up so much, eventually there's nowhere for it to go but out the bottom of your skull, okay? Or potentially out the hole that is in the side of the skull, if there is an actual hole in the skull. A lot of these patients that actually have open head injuries do better than fully closed head injuries, right? Because there's somewhere for the pressure to go. So we don't carry 3% saline, but your crit care teams carry 3% saline. Okay. It might just be a quick reminder to whoever shows up to consider that type of treatment for your patient, right? Because they're going to be under the pump as well, right? So there's nothing preventing us from saying, I think this patient might be coning, they might be herniating here in the future. What does that look like? Looks like a seizure, looks like decorticate or cerebral posturing. Looks like a low GCS, generally lower than 8. Looks like focal neurological kind of symptoms, one blown pupil, right? Trismus, one-sided stiffness or paralysis, right? Okay. What we're talking about there are specific neurological findings for patients that might be coning or might be hemorrhaging, right? So, and for pediatric patients, is this new or has this always been on this protocol? Lorazepam and Bedas for prophylactic seizure?
Back in the good days.
Because we talked about this with Keppra a little while ago, and
Yeah.
there's not a lot of evidence for that, but is that new? I can't remember if that's new or old.
That's probably an old carryover. We shouldn't be there.
Okay, maybe we
don't
can
really
bring that.
do prophylactics for seizure prevention and traumatic brain injuries.
Yeah, the data is certainly lacking on it. Like we did it for a really long time. We gave Keppra for it, and they'll almost always do that when they hit ICU. But
So it's like another, I think anytime you deal with a surgeon, you're gonna have they don't come to agreement very easily, but that's the more recent consensus is to do prophylaxis. Unless you have the neurosurgeon who likes it, then you do that.
okay. All right, so let's continue on with this patient here, right? We've got obviously a fairly hard fall. Bilateral eyes are swollen shut, Okay, so what that's kind of telling us, Mitch, what do you think bilateral swollen eyes shut are telling us?
He smacked his face good.
Yeah,
That's good.
smacked his face.
I mean, he fell.
Skull fracture, yeah, base of skull. Yeah, yeah, so anatomically speaking, when you get, both of your patient's eyes are swollen shut and black, what do we call that?
Oh,
Close? Raccoon eyes. What's battle sign?
it's like behind the ear. isn't it?
Behind the ears. Good, good.
Yeah.
I'm sure he did. Yeah, I'm sure he did. So, yeah, this guy's fairly beat up, right?
How many times they keep you?
So looking at our activity for this patient, right? So we've got some IVs going in pretty quick. The patient needed to be restrained. We've got a fairly low blood pressure to start with, right? We've got a pulse of 116, a blood pressure 90/60. Got pretty good SATs and respiratory rates, not too bad. Our second set of vital signs look a little bit better from the perfusion perspective. But our saturations are not looking really good, right? So this patient was kind of all over the place. He kind of had a really, really soiled airway, right? We know that, from actual people who were there, so Josh was there. What did his airway look like, Josh?
It was junk. It was full of blood and vomit.
Full of blood and vomit. So this patient needed immediate, pretty much, what I would kind of call a crash airway, almost, okay? I think you guys did an excellent job getting some fluid up on this patient, right? We've started to normalize our blood pressure. Probably a little bit of that's coming from getting the patient into an area where we could manage their airway, manage their hemodynamics, right? We've gone with 100 of rock. I love it. Round numbers. Awesome, awesome work. Nice round numbers, 100 of rock. Accommodate of 30. Awesome job again. Nice round numbers, right? We got an adult male. What do you say? How tall was he probably?
Oh, he was about 6 foot.
Perfect. So he's probably got an ideal body weight of 80 kilos. That's six foot, right? Ideal, yeah. It's probably closer to 100. Most people closer to 100, although this guy just got out of jail, so maybe a little bit thinner. Sometimes they're thinner, sometimes they're bigger. Just depends. But I really like the nice round numbers that we have here, right? We've got a combative head injured patient that's being managed very quickly and very aggressively because the airway is heavily soiled, right? We've got an 8.0 ET tube, 23 at the teeth, video laryngoscopy. We've got a grade 1 with a stylet used. So we had really good view of what we were intubating. And we had a MAC 4 blade, right? Our blood pressure on induction or just after intubation is kind of what we see a lot with head injured patients, right? Laryngoscopy is not a pain-free procedure. In fact, it's quite painful for most people, even if they are semi-conscious, right? And 170/103 is likely a physiological response to laryngoscopy, okay? Now, what we didn't have in our induction was any type of pain management, right? Would you argue that pain management is appropriate here? Or would you argue that this is such a crash airway that rocketomity is the best approach? I'm not there.
I
I
don't
don't
think D stands for analgesics, so I would go with airway first.
Airway first.
Yeah.
Yeah, we didn't have time to screw with that.
Yeah.
We needed to get an airway on him. We needed.
Yeah.
I think there's a line and there's this thrashing.
D stands for analgesics.
I don't know why. Yeah. In 1939, continue thrashing around. I would consider that like, get him sedated, get him paralyzed, get the job done, worry about pain later. Because like he's obviously shown to be a hazard to himself in that sentence right there when he's probably not even fully on the gurney. He was fighting with Josh and Noah and Penny and
Yeah.
who knows who's there. I think pain's like one of the later things that I'm thinking of?
I mean, so there's a lot of different ways to skin this cat, right? Which is the idea that I want to bring up, right? So if I'm walking into this scene, my first instinct is going to tell me intramuscular ketamine almost right away, right? I'm going to look at this guy. He's thrashing around. He's not very easily manageable, right? I like to get ketamine early on board with these patients so that I can resuscitate them a little bit, right? But I'm not there. The airway in this case was so heavily soiled. I don't disagree with what you guys did, but there is alternatives, right? So what Mitch is explaining here, a good dose of ketamine, right? It's hemodynamically stable. It's going to give you analgesia and sedation in one drug, right? And maybe allow you to intubate the patient just as fast without any other deleterious causes, and also blunt the pain response of intubation, right? That's an alternative take on this, right? I'm not saying that it's better because I wasn't there and it didn't happen. So, but it is an alternative approach that you certainly could consider, okay? It's within guidelines, and it's also probably widely used in EMS in other areas that don't have etomidate available to them. They would use, a rock cat induction for this patient, and sometimes they give the cat very early on in the piece because it makes your patient a lot more manageable. So that's just an alternative take. Right, so for this patient,
So
really,
excited delirium dose
That's kind of.
for your IM or for,
so I usually guide my ketamine dose based upon the patient's GCS, about how much fight they really have in them, right? So if they're like a GCS 10, walking, fighting, that's a big dose of ketamine, right? But a GCS 7 for a guy that's he's not able to mount a really aggressive response, right? You can probably use a much smaller dose, right? A 1 milligram per kilo dose.
And I guess my other thought with that is, I wouldn't want to do an IM medication without a good line I guess if that's what you're asking, it's just if his mouth's full of crap, he's gonna aspirate. So I'd probably want to make sure I had a good line and probably do RSI dosing just because of that context.
Yep. There's quite a few different ways to approach this patient, and that's a fair assessment for sure. This is a really unstable patient. Right, so we've had an issue with our tube here, okay? So we've had an issue where our tubes become displaced at some point during the treatment of this patient, right? It's recognized really well. We've managed that nicely by reintubating the patient. This is a really common occurrence in somebody that has a heavily soiled airway, okay? And also requires a lot of suctioning and other things going on with the airway, right? Many times when we go to, attach these patients to BBMs or ventilators, right? Our specific securement style, right, with our in the mouth, clamp down securement, if that tube is covered in blood and other things, it's very slippery inside of that securement device. All right. So to prevent an extubation in many of these cases, you could consider tape on top, right? Tape on top is going to help lock that tube into place a little bit better. And there's a little bit of research to show that ties or anything that goes around the neck of a patient who's got a traumatic brain injury can help increase the intracranial pressure because we're reducing a little bit of the blood flow that's venously draining out of our patient. So you could just consider tape altogether. But this is a very difficult patient. I'm guessing they got blood and vomit all over their face, which makes things even more difficult to manage. So this is not a patient that I'm like, oh my gosh, how did this patient get extubated? If it's gonna happen, this is one of the patients that it's gonna happen on, right? But the recognition of it was fast, the changing of the tube. Great job. Like, this is always going to happen for some of our patients, right? And what we did here by recognizing it right away and re-intubating the patient, okay, was done very well. And Josh, you were there.
Yeah, we picked up on it fast. We'd have picked up on it faster, and I'm not trying to knock fire, but we had fire bagging for us, and they didn't bother to say that they couldn't squeeze the bag.
Yeah.
And so, you know, after 2 minutes of them bagging the patient, I finally took the bag and it's like, holy shit, this is wrong. And he's like, well, yeah, it's been hard the whole time. So I call that shit out, you know?
Yeah.
We need to know that right now.
Yeah.
And so that's when it could have been picked up a lot faster, I feel, if we'd actually been maintaining our own bag.
Yeah.
But
Yeah, and there's a real, and there's another confounding factor in an extubation, right? When we hand that tube or ventilation off, you know, I'm not gonna say that they're an unskilled provider,
Right.
right? That would not do their skills justice, but they're not a highly skilled provider like yourself.
they don't,
Not
have
a
the
highly
time-
skilled
they
provider.
don't have the time on the bag.
That's correct.
And so they don't pay attention to moving it. They don't pay attention to holding still.
Yeah.
Restrictions.
So it's a really good point to bring up when these patients are intubated. Ideally, the person who's going to be in charge of that patient's airway is going to be a member of MVP staff. Right? Now, in a cardiac arrest, that's a little bit different. Okay, you might be utilizing somebody that you trust to, you know, to bag an airway, especially if you have a supraglottic in place. Right? But if you're doing bag mask ventilation, probably a highly skilled provider is necessary, right? If you're managing an endotracheal tube, a highly skilled provider is probably necessary, okay, until you can get that patient onto a vent, right? So those are just considerations for us all. You know, I can't tell you what to do in these situations because they're dynamic, but they're just considerations, right? So our post-intubation vital signs are looking pretty darn good, right? We've got normal hemodynamic pressures. We've got a good, you know, pulse rate. We've got a good end-tidal CO2. We've got the patient going on to the vent, right? With appropriate settings, except for the FiO2, right? What FiO2 do we start all of our patients on when we put them on the vent? 100. Very good. So it's really, really important. And, you know, the reason that it's preset to 21 is the fact that we don't want the thing alarming at you right away. Okay, as soon as you turn the device on. If we preset it to 100, it kind of complicates things because the thing starts screaming at you right away. Okay. It's not always hooked up to oxygen. And so that's a difficult kind of task to change that. But it's something that has been a repeat issue that I've seen on a lot of the charts. And then also on several patients that have been tubed by us. I've had people come to me and say, yeah, the patient's SATs went from high 90s down to 92. And I was like, what is going on? Why? And then they've come back to the vent and gone, still on 21%. Okay. So have it, try to drill it into your mind, 100% on your FiO2. Okay.
I think that's like the initial starting point. You're probably gonna be, you know, after intubation, you might be a little hypoxic. You know, and in the perfect world, then titrate it down from there, so you're not hyperoxygenating, but definitely in the initial phase, I agree.
Yeah. I mean, if your patient's already at 100% oxygen and they've been on 100% oxygen for a long time and their SATs are 100 for the last 10 minutes, you could probably start titrating down very quickly. But we want those first 5 to 10 breaths on a vent to be 100% oxygen, right? Hyperoxygenation really only starts to become a problem after 15, 20 minutes. We're bringing our partial pressure of oxygen in our bloodstream up significantly after that time frame, right? A little bit high is not bad for these patients, right? Long periods of time, not great. But all the rest of our parameters look really good. We're on assist control, our rate's correct, our PEEP is correct, tidal volume, right? Maybe a little bit low on tidal volume, but you know, for a 6-foot guy, I'd probably have a tidal volume that's a little bit higher than that. I'm not sure if we're following the chart exactly there for 400, but try to follow your charts. Your peak inspiratory pressure, perfect, 24. IDE ratio, perfect. So this is all looking really nice. Right, so we radioed in, and these are our remaining vital signs for the patient. And I wanted to just briefly discuss why we're probably seeing the escalation in our vital signs, right? Gone ahead, we've secured a tube, secured the patient hemodynamically, right? And now the pain is probably creeping up for the patient, right? So we've got 50 of Fent going in. Great, we got some Fent going in. That's what we want for sure, okay? But what really is kind of a balanced sedation for this patient? Remember, this patient has had no pain relief up until this point, right? So this is a consideration for your patients like this in the future, right? What does it look like? What does it look like on our chart? Okay. If we're going to go down to sedation and analgesia, right? We've got ketamine, 1 milligram per kilo. I think that's a great choice for this patient. I think it's a really great choice for this patient. It's quick, it's easy. The other thing that you could certainly consider is if you're substituting ketamine or etomidate in your induction, you've already got ketamine drawn up, right? It might also, the induction dose of ketamine at 2 milligrams per kilo might have sorted out your sedation and analgesia if you're in town, right? Because the half-life of 2 milligrams per kilo of ketamine is a pretty good amount of time, right? For sedation and analgesia. So that's your first consideration. You can certainly go with ketamine. Your second consideration of fentanyl, right? We're looking at an IV dose of 1 to 2 mics per kilo, PRN every 5 minutes with a max single dose of 100 mics, okay? So this patient could have received 100 mic pulse of fentanyl. That probably would have been a little bit better for the patient considering their hemodynamic profile, right? We've got a really good blood pressure there, 180 over 77, 170 over 100, right? These are pretty good pressures, right? That would lead me to believe that 100 mics of fentanyl would be an appropriate dose for this patient. Dr. Burris, what do you think of that? Yeah, nice. If you're going to go with fentanyl, we're going to be looking, because fentanyl is just a pain relief, right? It's just analgesia. It doesn't really give us an amnesic effect at these dosages. Much, much higher dosages will have an analgesic effect. And in fact, they're pretty much a general anesthetic at much, much higher doses. But we want to tag on a little bit of an amnesic drug, right? Which is Mydaz, right? Which is why I really love ketamine so much in many of these patients, because it's a single drug, it's a single dose versus 2 drugs on 1 patient, right? You do want to consider a few things with ketamine, right? Is your patient really hypertensive to begin with? It could exacerbate that. Is your patient really tachycardic? It could exacerbate that. Ketamine could possibly bump those up just a little bit. So if you're looking at the correct drug for the correct patient, have that consideration in mind, okay? So these are really, you know, what's your induction? What does your sedation strategy look like for these patients? On the right, these are just some options that you could consider, right? You could consider going a pre-med for this patient, a fairly light pre-medication because our patient was definitely teetering. I would have called that more of a crash airway, so I think the approach that you guys had was correct. I don't know if I would have pre-medicated this patient, okay, for pain. Just not enough time, not enough hands.
That wasn't even an idea.
Yep.
We wanted to protect you.
Yep.
And that was our number one goal.
Yeah, I think that's the right choice. You could substitute your etomidate for ketamine, right? You could substitute, you know, your fentanyl sedation of 50 with a higher dose of 1 mic per kilo or up to 100. Okay, and then tag on a little bit of Midaz on the back end. Was there, this was not one of the patients that we had with seizure pathology, but that one comes a little bit later.
Well, I mean, he was shaking when they tasted him.
Yeah. It's a seizure. Okay, so we can see, this is our patient follow-up for this gentleman, right? The CT of the face. He's got multiple fractures on the right side of his face. You know, he's got an orbital fracture. He's got a zygomatic arch fracture, which you can see in both of these highlighted photos, right? And then his CT head, right? He's got an inferior frontal lobe intraparenchymal hemorrhage, okay? He's got an extraaxial subarachnoid hemorrhage. And he's also got a moderate sized scalp and supraorbital hematoma. So his face is busted up. His head is busted up. He took a really, really hard fall. Okay. This patient is alive. He's doing okay.
He's back in prison.
Yeah. He's under care still. He's recovering from his brain injury. So he doesn't have all of his adult daily living standards met yet, but the expectation is that he's probably going to. So great job. You guys did a great job. So what challenges did this job present? Do we have Kenzie? We do. Kenzie, talk us through the great job that you did here.
Kenzie's got her hands, so. She probably, she may not be able to use the slides.
Yeah. She came off mute for a second and we remuted. That's okay. That's okay. We had a discussion about the case. You wanna say something?
Can you guys hear me?
Yes.
Okay, what was your question? Sorry.
Oh, I'm just saying, walk us through the hard parts of this case. What do you think you know, would change if you did anything, or what do you think went really, really well?
I think it actually went really well, especially with this being Noah's first RSI and Josh saying that he was playing close, so he wasn't there. But having Josh as a backup set of eyes for what I was doing and what I was seeing worked well. To do it again, I would inflate my cuff on my tube the first time.
Yeah,
But
I've
other
done
than
that
that, I
before.
think we worked great as a team.
Great. Well, yeah, I think it was a great job. Thank you very much again for bringing it to my attention, because that's how I highlight some of these cases for review. So thank you very much for your great documentation, and also for letting me know about the job.
Yep.
All right, let's go into case number 2, 64-year-old female. Here's our sporting. We've got a bicycle versus vehicle. Our initial impression is that the patient had suffered a traumatic brain injury. It was a pretty good hit. And we treated and ASL transported the patient. So we've got a little mix of case sheets together. Just put the filters on cigarettes, my goodness.
Too much money combined without.
We've got a good shoot time here. We're at the patient about 10 minutes after we went en route. So we had a little bit of a response time here. and we are leaving. Well, they're loaded up and in the aircraft about, let's see, we got 22 minutes later. Again, under 30 minutes for an RSI in care. That's pretty awesome. This one, we're out in, I believe we're in Kimberly for this.
Way up on the mountain.
Yeah,
This-
it was
this is-
Kimberly.
Yep. Yeah. And so we've got Amy, Taylor, James, Gary, Chad, and Brandy, right? So we've got lots of ASL and MVP staff. And this is a really cool job. So we've got a vehicle versus bicycle. It wasn't necessarily visualized, but come to find out, somebody had actually videotaped the incident happening. There was video footage of this. So that I found that pretty interesting. The patient has an altered level of consciousness with non-purposeful movement, small amount of vomit in the airway. Our mechanism of injury is a car failed to yield at the intersection, and the suspicion was the car was going somewhere between 25 and 35 miles an hour. So it's not a high speed, but it's certainly enough to hurt this patient, and it definitely has. The patient has not been conscious since the accident, which is a pretty bad finding. This patient's eyes are not swollen shut, so we did a assessment of the patient's pupils, which is a really great thing to do, right? We want on all of our traumatic brain injuries to assess pupils. That's really going to clue you into somebody who might be herniating or having, you know, a very, very bad head injury. Our GCS is 7, so that's not great. We have a moderate to severe traumatic brain injury for sure for this patient. Airway was compromised due to the mechanism of injury, and it was secured initially manually. We've got some labored and noisy breathing. The patient has good hemodynamics. They're pink, warm, and dry. They've got strong pulses, and a helmet was worn. So that's obviously helped this patient's brain a little bit. This documentation is phenomenal. So thank you very much for that, Amy. We don't have any step
welcome.
off. The chest is stable and intact. There's no visible injury to the vast majority of the patient, right? Which, you know, if we're going to be looking at a patient who has polytrauma, okay, a blunt polytrauma, that complicates our treatment for many of these patients, right? Because if they're bleeding to death and they've got a head injury, it makes it much more difficult for us to manage these patients. But this patient was fairly atraumatic, except for what we were finding with the head, okay? So you notice that the patient had a little bit of facial droop as well. I found that to be quite interesting for this patient, or their face was asymmetric, okay? That's a very interesting finding. Walk me through that, Amy. What kind of clued you into that?
Once we got her on the scoop board and moved into the ambulance, she was just kind of moaning and groaning and not really purposefully moving. So we were looking at her pretty close, doing a full trauma assessment, and it was just a little droopy on the one side. So we thought, well, did she have a stroke and that's what caused this? Just basically running through what could have caused her to get hit by this car, and are we dealing with medical and trauma, or is it just simply traumatic injury?
Yeah, that's a fair thing to kind of think about. Many of our traumatic injuries are caused because our patients had a medical episode, right? A syncope, fall, hit a head, right? A medical problem turned into a traumatic brain injury, right? Or somebody driving a car had a heart attack and crashed into a tree, right? So that's not necessarily out of the realm of possibilities.
Just a second. Who's parked in front of the security truck? We'll move it. Please, thank you.
You got it right, Mark.
Thanks, Andrew. All right, let's watch a little video here. Found this one quite interesting. Oh, yeah.
Nice.
Gets your blood pressure going. Oh.
See that one?
Right. That one definitely could have turned out a little bit differently, right? So, half of a second. He would have been going down the hill half a second sooner. He would have been in front of that car and potentially underneath it, right? Or through the windshield. There was another really cool video, but it was age locked because the guy got absolutely clobbered. But you kind of start to look at the pattern of injuries for these patients and what happens when a bicyclist is kind of T-boned by a car, or a bicyclist runs into the side of the car and actually T-bones the car instead, like that young man did, right? So the patterns of injuries are a little bit different, right? In this case, our patient actually in the car was in front of the bike. So the bike actually T-boned the B pillar, right? Which is much better than the bicyclist getting hit by the front of the car and getting thrown into the windshield. Okay. And then again, off of the car. Okay. So you look at how the patient is hit will lead you to suspect how many injuries they have to their brain, right? The initial impact, okay, we can get that contra Q injury, that whiplash to the brain, the head impacts the windshield, another injury, the head impacts the ground, again, another injury, right? Versus just T-boning the car themselves, their head is going to hit the B pillar, and then they're going to hit the ground again, okay? So there's one less impact there to be suspicious of, right? So trying to nail down exactly what happened in that mechanism of injury is very important, which was done here. Right, so we've got really good care going on for this patient. We've got a set of vital signs that's letting us know our patient is hemodynamically stable, right? We've got pretty good blood pressure. We've got a pretty good heart rate. SATs are good. We've got some IVs going in right away. We've got high flow oxygen going on right away. We are preparing our patient because we can see the writing on the wall, right? So really starting those 7 Ps for this patient: pre-oxygenation, preparation, okay? Our next set of vital signs looking even better, right? Our management of the patient is going really well. We've got excellent documentation again. We're doing a secondary head to toe of the patient and looking for anything else that might be a problem for our patient. and we're getting some fluids into the patient. That's a really good call, okay? So what does everybody kind of think the normal fluid amount that we're gonna do pre-induction? What's the normal fluid amount pre-induction for our patients? Yeah, yeah. So it depends how big they are. Perfect. Do we have a specific milliliters per kilogram that kind of comes to mind? 10. Nice round number. Perfect. Right. So 70 kilos, 700 mil. It's right on point. It's exactly what we want. So think nice round numbers for these patients. Okay. If they are tachycardic, that's leading you to believe that they are compensating. Right? This patient is a little bit hypertensive, but not wildly hypertensive. So I still like that we're giving this patient a 10 mil per kilo fluid challenge. I probably wouldn't go more than that, but that's exactly where we want to be, right? So great job. We even have a 12 lead performed on this patient. I'm thinking that's probably what you were looking for when you were trying to differentiate between medical and trauma, Amy?
Yep.
Nice, good work. You got your procedural pause documented, and then you've got a really, really important part of the puzzle here, blood glucose. Right? The blood glucose is very important for all of these patients. It's going to differentiate, your potential for intubating somebody with a glucose of 40 that just needs sugar, right? And then they wake up and then you're like, ooh, that was not great, okay? We don't want to be RSIing patients that we have not taken a sugar on, right? A crash airway is a slightly different set of circumstances, right? So in our first case where we didn't have a blood glucose before we intubated, that's okay. That person was drowning in their own vomit and blood, right? Clearly indicated. But after the intubation, we still want to get a sugar because any brain that's injured needs a couple things. It needs oxygen, needs glucose, and it needs good circulation to move those things around and the waste away from the brain, right? So great job getting a glucose here. Heart rate, looking good. Blood pressure's looking good. Pre-induction, ASL2 has arrived. So we've got plenty of skilled hands, right? We got the guy with probably the most tubes in Magic Valley history over here. James.
I don't know about this.
We got Chad, probably not too far behind. Okay. Amy's probably slotted a great many tubes herself. So we probably have a combined 1,000 tubes in the back of the ambulance. Right. So this patient's in really good hands. Was it at this point when you guys were thinking differentiating for a seizure, and that's why you gave them a DAS?
Yes, she had, I think it was a right upward gaze. And then she had some nystagmus. Her eyes were bouncing a little bit. And then with her non-purposeful movement / posturing, we were like, well, maybe she's just been seizing this whole time. And it was just kind of a last ditch effort of, will this fix it? And we don't need to tube her, or are we going to go ahead and tube?
Yeah.
She didn't have a lot of trauma, that's the thing. She had
Yeah.
a helmet on, so it wasn't like major trauma. She really the side of the car. So that was the kicker. We're like stroke, seizure,
Yeah.
okay, trauma, but yeah.
Yeah, I think it's a good differential, right? You're looking after your patient here. You're really doing a deep dive into their neurological presentation, and you're trying to treat the patient appropriately. So I don't see anything wrong with giving this patient a bit of a DAS. I think it's a great call. And for the longest time, almost all of our patients' inductions were morphine and midaz, right? So it's a mainstay of pre-medication for many of our patients that get RSI. So we've got a secondary IV established. Again, this is gold standard stuff. This job is going exactly like it should. Nice round numbers. Again, 100 milligrams of rocuronium. Nice round number. Perfect. Absolutely perfect. Pre-treatment, 30 milligrams of etomidate. Perfect. Round numbers. And a touch of Versed. The airway went pretty uneventful. We got a 7.0 tube, 24 at the teeth. You got a size 4 McGrath used, stylet. It's a grade 1 airway, I believe. And Gary slotted the tube, is that right?
I did.
James did. Why does it say Gary then? Oh, ventilation by Gary, sorry.
Yeah.
Right, so James slotted the tube. Easy, good airway?
Easy, except for catching that tooth, changed it out.
Yes, yeah, so we'll talk about that. Yeah, so did she have broken teeth?
No.
No.
I don't know what
She must have had one that was chipped.
Only thing is we just kept everything, I'm like, man, I'm hearing something's changed. I'm like, well, let's check the cuff again. And by the time we got to the aircraft, I'm like, I'm hearing it again. I said, yeah, you got a blown cuff.
Yeah.
But Chad would let me change it, of course.
I can almost
Didn't even do this.
I almost guarantee you, she had a chipped molar. That's what gets them 90% of the time. And it's happened to me countless times. And I've been asked to come in and intubate people that other paramedics have intubated. They just can't figure out why they're not getting stuff sorted out, and it's all cuff related. It's all cuff related. Methamphetamine was a real problem for people's teeth there for a while. It's a real problem for people's teeth.
Now, that's.
That's a real problem. That's it.
Yeah. Well, you know, like fentanyl kind of took its place for a little while, and you don't burn your teeth out with fentanyl, so. I like it. Right, so we've got a successful intubation, placements confirmed. We've got good auscultation. Again, documentation is superb here. This is some of the best documentation I've seen. We've got a patient with who's now being loaded into the aircraft. We got a good end-tidal CO2, and that's where we switch over to our Air St. Luke's chart. And I didn't go through the whole Air St. Luke's chart because that was quite long. But we can see our post-intubation vital signs, okay? So this is a very interesting presentation, okay? We've got a significant reduction in blood pressure, right? So that hemodynamically stable patient before is now hemodynamically questionable. I wouldn't say unstable necessarily, but questionable. And that 700 mil of fluid is looking like a really important piece of the puzzle now, isn't it? I think without that 700 mil fluid bolus in our pre-induction, we would be potentially seeing that blood pressure a little bit lower. Okay. Did we have a little bit of epi drawn up for this patient at all?
We did.
No?
So.
Okay. Just a consideration again, no matter what your patient's looking like, okay? It's not a terrible idea to have a little bit of push dose epi available for situations like this, okay? We've got a heart rate that's dropped down below 100. We've got a pressure that's below 90. You know, 100 is kind of where we're shooting for these patients' systolic blood pressure to be at, okay? Our mean arterial pressure is too low, right? We want to shoot for 65 and above.
I thought, you know, earlier you were asking a question, Mitch, about the blood pressures. And in this case, I'm a lot more concerned about hypotension in a traumatic brain injury patient. So, you know, I'll second that, you know, that's kind of where I see us working on it more rather than treating the highs. So, you know, definitely want to keep that brain perfused as well as we can.
Well, When we get like a blood pressure of head injuries, which happens quite often, especially in the hernia of like 190 or 130.
Yeah, in that case, like treating it would be bad, right? It's like you're trying to perfuse that brain.
Yeah,
Yeah.
but listening to one of the many EMS One Academy, they were talking about ketamine and increased cerebral perfusion pressure. And are assigning those patients and possibly raising the blood pressure more. And I was like, okay, but then we used to have lidocaine for that, but we don't use lidocaine anymore. It's proven not to work, which
Yeah.
decreased cerebral edema.
So that patient would be like a good fentanyl treatment patient,
Okay.
right? Like we were talking about. So yeah, that I would, if we're gonna treat pressures on the high end, I'm thinking pain management.
Okay.
But the low end, definitely we have the tools for that. And I think in, most cases, it's the hypotension that's gonna kill them or cause brain injury, because we want to keep that for cerebral perfusion pressure.
So we have, the treatment, like the protocol we just saw for two guys was the Dazzlam. The max we carry is 10. Like amongst 5 vials, 2 milligrams, 2 mL, 10 period. Should we start going up to the 5 milligram, 2 ml vials?
Well,
So we
I
have more or
I
something?
don't know if I would be Versed, I would be more like,
Well,
I think fentanyl.
well, yeah, but I'm talking about like post sedation, man.
It's for sedation, we could look at that.
Okay.
Yeah, certainly, depending, I mean, it's case dependent, but
Yeah.
I'd probably rely more heavily on the fentanyl than looking at.
Okay.
Yeah,
Yeah, especially if it's
Yeah, we
strong,
do.
I'm give that.
and we do. Okay, I'm sorry, I just want to make that point that that's definitely the goal here is to not under perfuse.
We missed, blood pressure or anything, we were taking her out of the ambulance and putting her in the helicopter, that's when she herniated. Cause her blood pressures were up, her heart rate's up, now that everything's low, did she herniate in that time frame that we're loading and not having her really on it? I mean, she's on the monitor, but taking it off and they're putting theirs on, we missed that.
True.
So this patient is doing really well.
Yeah, I guess you didn't hear it.
She didn't hurt him.
She did?
She's doing really well.
Oh, good.
Okay. I'll skip ahead to that.
That makes sense. Well, I'm just trying to figure out why the blood pressure drops so quick.
Yeah.
Cause you know,
Yeah.
you get that, as soon as they herniate, then everything goes crap.
Right, you're
And
right.
then they kind of stabilize again, so.
Right.
So-
And realistically, what can we really do for the patient,
Exactly.
We have to kind of accept that, but yeah, good thought.
So the question for me, right, with this patient, and again, this is a fairly standard induction minus the etomidate, because I didn't have access to etomidate when I was doing RSIs. In Australia, it's not TGA approved. So the drug here that's pointing me towards the reduction in blood pressure is the Versed. The Versed, yeah. So, and I'm not sure how you feel about Versed in pre-induction or induction phases. Obviously, you guys initially treating a seizure, right? I've seen in almost all the inductions that I used to do with morphine and Versed, a precipitous drop in blood pressure. And most of those patients I started on inotropes or vasos before I induced them, because I knew that 10 milligrams of morphine and 5 of Versed were going to drop their pressures. So I'd start them on a low dose NORAD infusion to just mitigate that in the first place. But if anything was pointing me towards a drop in pressures, it's probably the I think you guys gave 4 of Versed total.
She got total.
Yeah.
The atominator drop her pressure.
But that was also over, a 10-minute time period. So that's probably what I would think. Etomidate, all of the evidence on etomidate is that it's incredibly hemodynamically stable, especially for traumatic brain injury patients. But, yeah, that's my take on it. We did a great job, Chad and Brandy did a great job. They backed their blood pressures, right? So they went, is that real? Yes, it is. Okay, let me figure that out, right? And we've, probably given a bit more fluid here. It might not be documented, but we've probably given a bit more fluid. The patient's blood pressures come back up. Is a transient drop, okay? And what's acceptable for a transient drop? In theaters with a very healthy patient, when you guys go in to do your airway placements, eventually, all of you hopefully will go and do your airway placements, Michelle.
Yes.
You will see that the CRNAs or anesthesiologists are fine with blood pressures of like 70 on 30 post-induction, and they'll be like, it's just transient, it'll bump back up in 5 minutes time. Okay? And that's probably what happened here. There's probably a very transient drop in blood pressure. But for a patient with a traumatic brain injury, that could potentially equal a secondary injury, right? So 5 minutes is a lot, right? That's a lot of time, right? You're looking at about 450 heartbeats in that time if you're going with a pulse of 90. So that's a long time. So we want to maintain hemodynamics above 100 or a MAP above 65 if possible at all times with these patients. Now, we'll see later on, it didn't contribute to this patient's problems, but we continued down. We've given some hypertonic saline here. After we look at the CT and everything else, it wasn't indicated, but there's a lot going on for this patient neurologically that would also lead me to think potentially 3% hypertonic saline was indicated. Okay. So not necessarily a bad thing. Right. And, everything's looking to normalize here pretty well, right? We've gotten our pain under control. We've got sedation, analgesia going. So ASL is doing a nice job. And the rest of their chart reads beautifully. This patient stabilized for the entire flight really well, exchanged the tubes like you talked about, and everything went really, really, really well there. Right, so follow-up for this patient. They had a acute subarachnoid hemorrhage, and they also had post-injury seizures, right? So this patient had immediate post-injury seizures, okay? Which has been a discussion in our group for a little while now, whether we prophylactically manage these or not. This patient did have some Keppra, had some Midaz. Obviously, Midaz is probably the good choice for this patient in sedation. If you're thinking there's a neurological seizure potential, Midaz is a great choice for ongoing sedation for these patients, right? She had some other stuff. She had rib fractures, a small pneumomediastinum. She had a tiny subdural hemorrhage, and she did have a diffuse axonal injury as well. So that's actually what has caused her ongoing problems. Her chart on Epic obviously doesn't give me access to everything because she flew to, I believe she flew to Ermac. But the rundown is that she's now at home in Colorado with her husband, with almost all of her adult daily living standards back in place. She just has a difficult time tying her shoes and wiping her butt in there. So, but otherwise she can eat, she can dress herself, she can do most of those daily living standards that she otherwise would be able to do. And it's still early on in her recovery. So hopefully she continues to recover more into the future. Right, so I left this one blank. What do you think? So we had etomidate, rock induction. We had a tiny bit of pre-medication with Versed. Dr. Burtis kind of gave us his take on it. He was thinking fentanyl for this patient and pre-medication.
I guess you can almost, in a sense, that the Versed could have been a pre-medication in some sense, not for pain, obviously, but
yeah,
for the seizure.
Yep. So anybody else? Anybody going ketamine for this patient?
Hypotension afterwards. In retrospectively, that would have seemed nice, but
Yep.
yeah, you would know that, sort of. We didn't know that from the beginning. So
Yeah. I mean, I think the decisions that were made were correct. Honestly, I think it was a great job by everybody involved. Could you have done it differently? Of course. Yeah. I mean, I would have traditionally not having etomidate. gone with ketamine as my pre-induction, and my induction, and my sedation. And then depending on what their heart rate was doing, I would have tacked on fentanyl to bring their pain response down, right? With a little bit more of an opioid. And the rock dose, I probably would have kept the exact same, 100 milligrams, right? So I think everything was looking really good for this patient. Those were the only things that I thought we might discuss there, so. Amy, anything, any other interesting points you want to share with us?
Just the chat that Chad had sent in. He said that she didn't end up with really anything other than a concussion. I think I remember something about a subdural, but all in all, it went smooth and we worked well together and she had a good outcome, which is lucky.
Yeah, yeah, I mean, I think the diffuse axonal injury is the thing that's continuing to kind of bother her a little bit, but she's definitely in rehab and doing pretty well by all accounts from what I can see. So I don't think she would have done nearly as well without all of you there in your tremendous treatment for this patient. So. Okay, case number 3, we'll jump into it. This one's a little bit quicker. Got a 66-year-old male. He was ejected from the passenger window during a motor vehicle accident. He was driving. So going out the passenger side window is an interesting way to exit the car. And he wasn't wearing a seatbelt, obviously. This one also has the interesting factor that the patient is non-English speaking. He is a Espanol only patient, okay? Let's have a look. Let's see. Oh, Jerome. Good work, Dan. Detective skills kicked in. So we got Garrett Holdeman. We got Andrew on this one. Andrew seems to be a repeat offender in my case. What is going on, dude? I don't know.
It's Spanish speaking patient. That's
Yeah. Shaver. We got the Shavinator. And we've also got ASL crew, Mr. Samuel Schwab. We got a great shoot time. We're at the patient pretty quickly, right? 11 minutes, not bad. And I'm guessing we have, let's see, 400 South, 400 West, Jerome. Is that gonna be Jerome County?
Yeah, it's county. Well, shoot, maybe.
Or rural, or what do we call it? Rural, don't we?
We call it 2 old guys that just show up.
Yeah. So, I mean, we should have plenty of hands here, and I'm not sure when everybody showed up, but do we have Garrett? Is Garrett on?
He's on a call.
He's on a call, okay.
Like it's Andrew.
No.
Right, so the patient was located approximately 10 feet from the passenger side of the vehicle on the ground, supine. He appears alert and looking around, but won't respond verbally, and he can't follow commands. So he can't move and he can't talk, right? But his eyes are open and he's actively moving and tracking, all right? It's a very interesting presentation. GCS of 9 for this patient. Pupils are normal. Hemodynamically stable, right? But still appearing to have traumatic brain injury, right? And he's ejected from a car. So you're pretty suspicious that he's got a traumatic brain injury. And then he's also got polytrauma of some type, right? So he's got a laceration on the back of his hand, but not a great deal else. You know, he's got a lac on the back of his head as well.
Was he drunk?
That one I can't remember. Our first patient was intoxicated. His blood alcohol level was, actually, it wasn't that bad. Yeah, his blood alcohol level wasn't that bad. I was actually impressed by that. But the patient is, is doing okay as far as being ejected from a vehicle. Like he's not looking terribly bad, right? Right, so what we've got here, we've got a patient who's really, really hypertensive.
Oh, there it is.
tachycardic, hypertensive. Right? Andrew's over here slotting IVs as usual. We've got a liter saline hung and going for this patient. Right? And I think, you know, again, in retrospect, we want to be giving all of our patients that are going to be inducted a bit of fluid. Okay? So I don't have any problem with some fluid going into this patient, right? You probably limit your fluid a little bit more in patients that are, you know, more of the classic multi-systems trauma patients, because you don't want to throw clots that they might otherwise have established, right? But this patient, from a head to toe inspection, really didn't look that bad. Some minor lacerations, all right? With all the bleeding control. Oxygen's initiated very early on. So we're pre-treating, pre-oxygenating really well. Again, we've checked a sugar. Excellent work. That is an integral part of making sure that this patient who's not speaking to us and not able to move is not just significantly hypoglycemic. Right, so this one, we went a little different. We went with the ketamine, okay? We went with ket and then rock for this patient, 160 and 80. Right, and we're going to talk a little bit about which one of these you give first, if you're going to give them, right, versus etomidate, rock. The intubation went really well. Garrett slotted the tube for us. We got a grade 1 view, 7.5, 23 at the teeth with a McGraw 4. And the decision was made, obviously, because the patient had what appeared to be a traumatic brain injury. Our post-intubation vital signs, right? And remember what we talked about before was ketamine is supposed to be a bump in your blood pressure. It's supposed to bump your heart rate as well. It's done the exact opposite here, hasn't it? We got 132 as a pulse and 215 over 127 for an initial pressure. Got 130 and a blood pressure of 100 over 60, right? Still within physiological norms. For me, I'm not too worried about that. But that is a precipitous drop in a blood pressure. Massive drop, right? So just know sometimes if your patients are in a lot of pain, that might be the precipitating cause of their hypertension and their tachycardia. When you give them an analgesia / sedation drug like ketamine, their blood pressure might come down because their pain response is now blunted, right? TXA is given, you know, ideally we're given TXA about 10 minutes earlier, right? When we get the patient initially, but I can't fault them, right? They had probably a pretty, you know, overloaded brain. Here it's still a fairly new medic, and this is a pretty difficult patient. Look at him in the face, and I think he's done an exceptional job. Patient care is transferred over to ASL, and we've got a few more sets of vital signs here that are leading us to believe the patient is kind of all over the place as far as their blood pressure is concerned, right? We're in a beautiful blood pressure range there, 160 over 100. You know, I'm quite happy with that. Maybe the diastolic's a bit high, but then we are sky high on the next one 5 minutes later, which is very interesting. Okay. The ASL chart is fairly similar to this. The gentleman was tachycardic for quite a while and had fairly high blood pressures throughout their transport. So I didn't include it, but that's just a talking point. Right. What's the consensus on giving rock first, then ketamine after, or giving ketamine first and rocuronium after? So you got the rocket amine versus the ketaronium.
I think you should always sedate your patients first. Honestly. Yeah, you're taking away their ability to breathe.
Yep, yep. All right, that's one take on it.
I'll say that sometimes I've done the opposite. If somebody's like, I need to get the airway kind of quick, the paralytic sometimes takes a little longer. That used to be the traditional teaching, sedate first. But if you're slamming them both in, sometimes I like, if I really like, oh man, I need to get this airway quick or something's kind of pressuring me, I'll sometimes do it the opposite way. But there's special circumstances that has become more acceptable lately. So if you felt like you're in a pinch and you like really needed to get that paralytic circulating, I chase one after the other. I think the paralytic takes a little longer to take effect. So there's a thought there that we can reverse that order. And that does deviate from like some of the traditional teaching. But I would support that if you're in a pinch and that's what you feel like needs to happen. I guess maybe I'm still in your thunder on that one.
No,
Yeah.
no.
Yeah.
You're leading us into our little infograph here, right? So when we look at how the drugs react in the body, and Dr. Burris really kind of laid it out there for us, is the rocuronium sometimes takes longer to set up than ketamine, right? Almost always takes longer to set up in our patients than ketamine. And if we're giving the patient a 1 milligram per kilo dose of rocuronium, it takes even longer, right? So this is based on a 1.4 milligrams per kilo dosage time frame. Okay, so you can see for our rock to set up completely, right? We're averaging somewhere around 1.5 minutes to somewhere between 60 and 90 seconds, right? Our ketamine generally takes somewhere around 40 seconds to set up. So the thought process on which drug to give first is now switching because of the setup time, right? And this is kind of why I like giving ketamine very early on in the piece as almost analgesia for the patient. I'm pre-treating the patient in the phase of building them up to an RSI, but that's more a delayed sequence intubation. It's just what I had started switching to considerably in my practice. But when you look at these graphs, it kind of lays out the rationale behind why you would give rock first, okay? We want to get the tube in pretty quickly. If we're giving 2 milligrams per kilo of ketamine, you can cause transient apnea in your patient, right? So your patient can stop breathing just with ketamine for a short period of time, right? Somewhere around the 20-second mark is what the evidence is showing us. And that could trick you into thinking that your patient is paralyzed and they're ready to intubate, okay? And I've had some people recently who have described this type of behavior in patients, right? Where they thought their patient had set up, they thought the rock was ready to go, they got into the airway and it wasn't working out for them like they were hoping, okay? Either difficult to intubate, probably because the patient still had airway tone, or the patient was gagging or actively resisting intubation, right? And that's a reflex. That's a deep reflex somewhere in your brain. So many of these traumatic brain injury patients, just because they have low GCS, 6, 7, 8, they will still actively fight laryngoscopy. They might vomit, they might gag on the blade. Last time I was vomited on inside of an airway was when this discussion started happening, right? So it's just a consideration for you that I think Dr. Burris would certainly support because the evidence is there, that if you see your patient, especially if you have a patient that is shocked, all right, and we're talking about hemodynamically stable patients here for the most part, but if your patient is shocked and not perfusing well, consider giving the rock early because that will delay the amount of time for your rock to paralyze your patient as well, okay? Rocuronium needs a lot of time to circulate through the system and actually paralyze a patient. right? So, and that's just the way that it's gone for us as far as paralytics are concerned. Non-depolarizing paralytics like rocuronium take a little bit longer to set up, but they're much better for a patient. So,
So, you said in special cases where you feel like it's needed, if you're in a hurry, I support that, but that does deviate from some of the traditional teachings, but you look at two different patients, it's a trauma patient, they're in bad shape, you need that airway. Make sure you have a good line, obviously, you can do that, and we have good justification for how long it takes. Maybe some of the breather patients where you have a little more time, you can still do the traditional order. I do swap it depending on what's going on with the patient in my own practice, so I think that's advisable.
and I've actually seen it in a few of our charts. I actually have seen it in a few of our charts where people are giving rock first and then etomidate second. Okay, so it's acceptable. It's okay. It's just a consideration per patient. We're talking pretty high level stuff here, but
Might just be the charting system.
it could be as well. Yeah.
Because you can adjust the times within 15 seconds and it's still only using the minute
Still swaps them.
and it'll swap them. So just because it's showing up in the charting system in that order, they were put boom, boom. And they're gonna show up. They'll flip flop depending on which one you clicked into last.
Yeah.
It'll become the first procedure of that timestamp.
That's a good
So-
point. That might have been what I was seeing. Yeah, it very well could have been.
There's always a lot of dogma with how things go, and I think it's a good justification that we never want to paralyze somebody without sedating them. But in reality, like if you look at the pharmacokinetics of the drugs, it is pretty reasonable to do it that way too. But it is, just because we did that for so many years, we could have maybe this would actually help us in some of those cases if we get that paralytic on board sooner. So just a thought. But
Typically, we've got a bolt drawn up. and-
yeah, you're kind of like, it's kind of, it's not a huge difference, Yeah.
He's intubated right now, right?
Yes, patients.
What's his GCS at the end?
Yes, I did see that as well. I didn't want to blast Garrett for that.
Well, it's a mistake I make.
Yeah, a GCS of 9 in an intubated patient.
The other question I had is like, did we check pupils on this guy at any point? So thought.
They said
you
equal
had mentioned that
reactive.
earlier.
Equal.
Equal, okay, thanks.
Yeah.
He might look around, but he wouldn't subscribe.
Yeah,
Uh,
I had copy paste because it's put a GCS everything or the timestamp box or so. And you're pissed off at you.
All right, our last one here. Does anybody think they would have done this a little different? I like the use of ketamine here. I'm a big fan of ketamine. I definitely would have considered pre-medication in this patient as well. I would have considered fentanyl.
Google Translate.
If you have the time, if you have the hands, right? The patient didn't look like they were massively broken from head to toe, all right? But I think that blood pressure is fairly indicative of pain, okay?
And for this being Garrett's first solo RSI, he did pretty darn well.
I think he did an exceptional job,
He
yeah.
did 2 tubes that day, this is his first one, and he's like, dude, I'm nervous, just walk through. I was like, dude, you got it, you're fine. I think he crushed it.
Yeah. Yeah, and I think this is a case,
First tube is in Jerome.
Yeah,
It's 30.
dark, cold, and it's the first tubes you go.
this is a case, I think that one of the ones that Ken brought up to give a kudos to Garrett on, right? So I think he did a great job. And not sure if Garrett's online now, but Andrew, any other challenges you saw with this job or anything that was,
I mean, just the normal language barrier. He's obtunded. You can't really assess him fully.
You sure the driver didn't run it? He just was checked.
So with the cop said that he ran and stopped the intersection, got tangled up in a barbed wire fence, and somehow flipped his little go fast Miata, and then ended up in the road. But
yeah.
yeah,
Right, so looking at this patient's trajectory, so he had a skull fracture with a right frontal and temporal subarachnoid hemorrhage. He had a small left temporal, left side. So he had a right and a left side, which is very indicative of being bounced around inside of the car and or his head hitting multiple things on the way out, both right and left sided. So he had another subarachnoid hemorrhage. He had a 7 millimeter subdural hemorrhage on the left side. He had another subdural hemorrhage. He had intraaxial hemorrhagic contusion, zygomatic arch fracture in his face, orbital wall fracture, rib fractures, adrenal hematoma, a pretty decent hand laceration, and that laceration that was also documented on the occipital scalp. So this guy's brain got juggled around really, really hard. And very interestingly, when I read the ASL chart, this guy was responsive. So they got him to the emergency department in Ermac. He woke up, they extubated him, and he went to ICU untubed and recovered. So he's home with his family, doing okay. Yeah, it's pretty amazing. So again, 3 patients all survived because of your superior care. So great job, guys. This is why we're talking about this, right? Fentanyl can lower intracranial pressure during RSI, right? Laryngoscopy is a painful thing to have happen to you. And so what we want to do is not spike your intracranial pressure if you already have high intracranial pressures. All these patients did well, right? But it is moving into mainstream RSI that we pre-treat these patients with fentanyl during the RSI, okay? But they need to be hemodynamically stable, right? So your hemodynamic considerations here, your patients should have a MAP of greater than 85 before you administer fentanyl, right? And this does confuse things, and that's why it was kind of taken out of the traditional teachings here in the past, was we don't want to cause more of a cognitive strain on you during what is already a very busy job, right? For you to consider these things. But given now that you have a checklist to use, right? You can have a consideration for your patient's mean arterial pressure, and that can help guide whether you're going to pre-treat with it. Right? Does everybody feel happy with that? Okay. And this is mostly for our traumatic brain injury patients, right? The use of, bronchotomy inductions for many of our medical patients is also suspicious to me, right? Like I don't want to be awake shortly after I'm intubated, right? Because our etomidate is not going to last very long after we go to intubate somebody. 10 to 15 minutes, our patients are going to be waking up, right? And so we want to have some type of analgesia or sedation on board for these patients. So fentanyl is a great treatment that we can utilize, right? Any considerations anybody wants to put out there? I know this is a little bit new. And I don't think Dr. Burtis, myself, Stan, or anybody is expecting you to change your practice overnight to include these on many of your patients. But this is just something, it's another tool in your kit to consider. Right?
Beyond the
Yes. I'm going to send out some information to everybody on some protocol updates. ASL got some protocol updates at their last meeting that I didn't see it in emails come out to all of us, but there's been some recent protocol changes. So I'll communicate that to everybody. All right. Any questions from those online? Sorry, we're 2 minutes past.
Scheduled till 10:30, so you're still doing all right.
I know, I said to 10 o'clock. I try to shoot for 10. Thank you very much, Dr. Burris.
So thank you, guys. Yeah, so we had gotten away from some of these pre-medication ideas, trying to simplify the process. We're doing so good with our intubations and everything. I want to bring this back a little bit. So when it's appropriate, when the maps are acceptable, let's try to incorporate that. I think it's because we've reached that level where we can even do better now. So if it fits into your practice, then adapt it.
Nice. Thank you very much. Anybody online? Very good. Everybody online, I'll be getting together with everybody to go over the new Neomate. But for those in the room, we're going to go over that very quickly for you guys so that we can start getting it on the trucks. Okay? Have a great day. If you have any concerns, if you have any thing that you want to talk about, just shoot me an email, a text. Please start working on your national registry if you're due to recertify. Get together with myself and/or Frankie is on light duties. So she can also help you a bit if you need. I'm gonna go over some stuff with Frankie. So if you prefer to see Frankie's lovely face over my ugly mug, then go for it. Thank you so much, guys. Have a great day.
On a picture. Trying to fish for email.
You can do whatever you St. Luke's.
All right.